Hi, bitch besties. It's your main bitch, Melly. Thank you so much for tuning in and welcome to another episode of the Judgy Bitch Pod. Hello, Dr. Fogelson. Welcome to the Judgy Bitch Pod.
Hello, Melly. How are you?
I'm good. How are you?
I'm good.
Thank you so much for making the time and coming on. I know you're super busy, but let's get started and tell my bitch besties, please, how you and I know each other.
Well, I'm an endometriosis surgeon in Portland, Oregon. I do surgery for women with endometriosis and complex pelvic pain. And then we have a podcast called the Endometriosis Podcast with my partner, Dr. Shanti Moling. And then I guess you heard that and reached out to me and wanted to chat. And I said, sure, why not? And here I am.
Yes, exactly. Thank you so much for coming on. The reason why I found this podcast is because I have endometriosis and I find that the topic is not talked about enough yet. I feel like it's almost like it seems like a new topic, although it isn't. But finally, people start talking about it. So I wanted to have you on to bring more awareness to the topic, so to speak. But I'm interested, you as a man, how did you end up in that field? How did that happen?
Oh, well, what is it, like 25 years ago or something, I decided I wanted to be a OBGYN. I just found affinity for it. I enjoyed back then. I delivered a lot of babies. Like I enjoyed delivering babies. I enjoy female patients, but at this point, I can't stand male patients. They drive me insane if I have one. I rarely have one, but I actually do a little bit of stuff that drives to male patients. They don't really. I mean, if they're listening, you're fine, but it's different. But then over time, I just became very interested in complex pelvic pain and endometriosis and got a lot of advanced training in that and ended up kind of making my life out of it. I mean, it's what I had been doing for the last almost 10, 12 years. All I've been doing is complex pelvic pain and endometriosis, and I've developed a pretty niche skill set in the surgery. The surgeries that are involved are pretty technical, and a lot of general OBGYNs who've just done gynecology training, and even people that have done minimally invasive surgery training, often don't have the experience to do really complicated endometriosis surgeries that I do a lot of. And most gynecologic surgeons have no interest in those surgeries. That they're scary and complicated, and it's
Yeah.
not something they're too interested in doing. So I've kind of made that my niche, and that's what I do. I mean, I don't think whether I'm a man or a woman has much to do with it. It's just sort of, I appreciate the opportunity to help the people I help. It's a very rewarding path.
Yeah.
Most of the people I take care of have been ignored, and in many cases have gone on years and years and years without a diagnosis. And physicians don't have a lot of training in endometriosis, so a lot of times they miss the diagnosis, and so it's really rewarding to come to the right answer for a lot of people, and we're able to help a lot of people.
Yeah.
Get through our door. We're able to provide a lot of benefit for most people.
Yeah, we need more of you. If we could clone you like a million times, that would be great. There would be more
It's
research happening.
It's growing. There actually is a fair amount of research in endometriosis. I mean, both NIH funding is, although with the current administration, NIH funding is kind of like gone. But, there was a decent amount of NIH funding in the last decade, and there's a lot of private money funding too, and research and diagnostics and some therapeutics in endometriosis. So there's a growing interest for sure, but it's dwarfed by like breast cancer funding or colon cancer
Right.
funding. Like it's just a drop in the bucket compared to those
Yeah.
things.
And I didn't research it, but I heard on another podcast or something that the fundings, for example, for prostate issues are much, much higher than any fundings for female healthcare. So we appreciate you. We love having you on our side and fighting for
That
you.
never will. I don't know what the funding they have for those things, but
Yeah,
but
it
yeah.
kind of makes sense. I believe it without seeing it. But, maybe if we start with explaining what is endometriosis. Can you explain in simple, easy words, like I'm a first grader, what it is?
Well, so endometrium is the lining of the uterus.
Okay.
Supposed to be there, but sometimes you'll get cells that are very much like the lining of the uterus growing outside of the uterus. And from a baseline level, anytime there's endometrium growing outside of the uterus, that's endometriosis. Now, if we get more technical, it's not really endometrium. I call that because when you look at it under a light microscope, it looks a lot like endometrium, but it doesn't act entirely like endometrium, and it's probably something slightly different, but it acts a lot like it. So when the lining of the uterus is going through its cycle to prepare for embryo to attach for pregnancy, the same cells outside of the uterus or similar cells outside of the uterus are also going through this sort of inflammatory cycle. And that's what's supposed to happen on the inside of the uterus. But when it happens outside of the uterus, you get inflammation, you get pain, you get scarring, you get nerve irritation, and people have, pain, infertility, organ dysfunction are kind of like the three major things. And then you can get other kind of what we call vegetative symptoms where people get weakness, they get pallor, they get slow heart rate, high heart rate.
Mhm.
Have so-called POTS actually have autonomic dysfunction from endometriosis is what's causing their autonomic issues. So it can cause a lot of symptoms throughout the body. And
Yeah.
it's kind of like a chronic source of inflammation in the pelvis. Just like if somebody has an infection in their foot, their whole body could feel horrible because your whole body is trying to fight this infection. And so every bit of the body is being exposed to this sort of inflammatory process. And endo can cause a great deal of problems. In some cases, it can cause a lot of invasion where it literally invades into the tissues of the pelvis, and it can invade into the nerves of the pelvis. It can invade through the bowel. It can invade through the bladder. Those are severe cases, but that's kind of what I do a lot of. The severe cases end up coming to
Mhm.
my a lot, and it's it can be pretty gnarly. But it also can just be little spots of endometriosis in various places in the pelvis. And one thing I tell a lot of people that like it doesn't really matter how much it is. If you have a really painful stimulus, it doesn't like the fact that it's a small thing doesn't make it less painful. If you have a little hot coal in your shoe, it burns and it hurts. It doesn't matter that it's small or big. And so I think there are people that say like, oh, that's just a little bit of endo. It can't be causing all these symptoms. And that's really kind of ignorant. I mean, you can have a relatively small amount and have it cause a lot of symptoms. And conversely, you can have a lot of endometriosis and sometimes not have a lot of symptoms. So sometimes those people had a lot of symptoms when they were younger, and kind of as it developed, it started to get kind of scarred over and a little less inflammatory. And also their immune system's not as strong as it once was.
Mhm.
Not so things aren't as inflamed as they were when they were younger. So it's a very diverse disease that can present in a lot of different ways.
Interesting. Do we know what causes it and when does it start? Does it start with women when they get their period or before or after? Do you know any about that?
There's definitely some different theories. It's kind of funny. There's a bunch of theories, and almost all the theories are old. Some people think that there's one old theory and there's new theories, but it's funny. You can go back 100 years and people were talking about the current theories too. So the kind of traditional theory is that the lining of the uterus is leaking out through the fallopian tubes during menstruation, and then it's sticking on the walls of the uterus, walls of the disease. That's the so-called retrograde menstruation theory. And then there are other theories of metaplasia, which means one cell type transforming into another cell type from some external influence. So you could have like the peritoneal cells in the pelvis undergoing some transformation into endometrial-like cells. And then there's the embryologic suggestion that you have sort of patches of tissue in the peritoneum that are kind of programmed from embryo level to one day become endometriosis. That's sort of the mulariosis theory. And interestingly, like all those theories go back. Some people think the mulariosis theory is very modern and the
Yeah.
retrograde menstruation theory is very old. You actually go back in the writings of Samson, who is attributed to retrograde menstruation. Samson wrote about all that stuff. Samson wrote about effectively mulariosis that David Redwine thought he invented. Well, Samson talked about it too, 100 and some years before. Um, there was genetic predisposition. There's talking about cell transformation and retrograde menstruation. And these all go back very old documents kind of, I mean, obviously they didn't even understand DNA 100 years ago, but people did have this idea of sort of predisposition to cell transformation even a long time ago. I mean, they had light microscopes, you know, Da Vinci time, right? I mean,
Hmm.
so I mean that's been around a long time. So, but nobody knows for sure. I think that endometriosis is like when people ask the question, what causes endometriosis? I think it's a bad question because I think endometriosis is not one disease state. I think
Hmm.
it's a constellation of disease states that have kind of similar appearance, but if you do endometriosis surgery, you'll find out it doesn't always look the same. In fact, it can look characteristically different where you see one pattern that you see a lot and then you'll see a different pattern that you see a lot, but you're like, well, that case looked a lot like that other case, but nothing like the third case. And then you see a bunch of cases that look like something else. So you start thinking, maybe this is 3 or 4 disease states and just like cancer is a lot of different disease states, we say, well, prostate cancer and cervical cancer and lung cancer, well, they're all cancers that share certain characteristics of being cancer, but then they also share some characteristics that are very, very different.
Hmm.
And I think in the same way, all cases of endometriosis share certain characteristics, but then have other characteristics that are quite different. And so I think that it probably isn't one disease. And for that reason, it probably doesn't have only one reason. And, we're still continuing. We're learning that now. There's still a lot of genetic studies going on. There's a lot of decent amount of research, and we're finding out more over time.
Yeah, yeah, that's super interesting. And that was actually one of the questions I had for you, if it's a modern disease or if it goes back in time, but you already answered that. Because for me, the first time I heard about it, I think was when Amy Schumer came out and said she has endometriosis. That was the first time I even heard about it,
Well,
not
it goes back
knowing.
thousands of years. Like you can go back into
Interesting.
like before Christ, Greek physicians wrote about it.
Wow.
I mean, they
Interesting.
described it as sort of like knots of inflammatory tissue at the top of a woman's vagina. So I guess they were doing some pelvic exams back then, and
Mhm.
then obviously postmortem autopsies were going on, but nobody was doing surgery.
Yeah.
Human physicians have known about it for literally thousands of years, and we have
Interesting.
continued to develop our understanding. And probably 100 years from now, we'll go back and look at my understanding of it and think it's barbarically ignorant, because we
Yeah.
now we're going to understand so much more about it. So science moves forward, but
Yeah.
it's
Thank God.
the state has been known for a long time.
Yeah. Can you talk a little bit about the main symptoms? Why do women end up figuring out eventually that they have endometriosis? What is for me, it was the heavy period pain. Is that like the common
Yeah,
factor?
I would say the most common is like unusually painful menstrual cycles.
Hmm.
A typical woman without endometriosis, and when I say women, I know some people who prefer gender neutral term of woman, person with uterus, and we can substitute that if you prefer. But basically, I'm referring to anybody that has a uterus that menstruates.
We're
And
inclusive here.
I fear it's a little cumbersome to say person with uterus over and over, but nonetheless, when a person menstruates, typically people, go about their day. Maybe they take some Tylenol and ibuprofen, and it's not some life dominating issue. But when a person has menstrual cycles that they have to put it on their calendar and say, I'm going to miss work on these days, or I'm going to miss school, and like this is going to be a bad week, and these other weeks are going to be okay. Like that's not normal. That's endometriosis.
Hmm.
And it's actually common enough that people are kind of tricked into thinking it's normal. I think sometimes even physicians have gone undiagnosed and they think it's normal because they have it too.
Right.
And endo's pretty common. It's about 1 out of 10 women have at least some endometriosis. And I have a very biased view, of course, because I'm operating on people with pelvic pain. Like I feel like I can find some endometriosis in anybody. But at the same time, how often do I operate on somebody that's not having the symptoms of endometriosis? So it's not really a fair example. But the big thing is really severe pelvic pain that's interfering with life. And I would
Hmm.
say if somebody has some pelvic pain, but they're able to take Tylenol or ibuprofen and go along with their day, I would say, well, they might have a little endo, but probably not enough to worry that they need to do anything about it. But when people start having endometriosis to where they're missing school and they're missing work and they're having painful intercourse and they're not wanting to have sex because it's painful, they're having severe bowel dysfunction where they have intermittent constipation and diarrhea. That's really common where people can get really, really constipated prior to their cycle. And then when they start bleeding, they get terrible diarrhea. That's very common in endometriosis.
Hmm.
Those things are common symptoms. And then the other big category is infertility. And people who have endometriosis, sometimes they may have pain and infertility, or they may have no pain, but they have infertility. They just can't get
Hmm.
pregnant. And they try for a long time to get pregnant and they don't. And sometimes they do in vitro fertilization and that fails. And they don't know why. And it turns out they have endometriosis. And
Hmm.
so, I do a reasonable number of laparoscopies for people like that who aren't having a lot of symptoms, but they can't get pregnant. And so they're concerned they have endo, and you scope them and they usually do.
Hmm.
It's those are the major symptoms, but again, there can be like sciatica, sometimes cyclic sciatica can be from endo, bowel dysfunction, autonomic dysfunction. It really can cause a lot of things.
And is it true that the only way you can really diagnose it is by surgery, by laparoscopy?
Well, that's the definitive diagnosis. And I
Hmm.
would laparoscopy by an experienced surgeon. There's plenty of people that have had laparoscopies and told they don't have endo when they do, because there's a lot of kind of subtle appearances of endo and people who aren't very experienced might miss it. But, there are imaging studies that can prove that someone has endometriosis, but there aren't any imaging studies that can prove that you don't have it. Like if I do an ultrasound and you have an endometrioma, which is like a tumor of endometriosis on the ovary, that's very visible on an ultrasound. And if you have that, you have endometriosis. And if
Mhm.
I get an MRI and I see evidence of deep infiltrating endometriosis on the wall of the bowel or the uterosacral ligament, which is down in the pelvis, well, then that person has endometriosis.
Mhm.
But if I get an MRI and it's completely normal, that does not mean they don't have endometriosis. Like if somebody has the symptoms of endometriosis, the minimum intervention is a laparoscopy. Like you cannot tell that person they don't have endo without scoping them. And usually they do. Like when somebody has the right symptoms, they've almost always got endometriosis. It's just there's not a lot of other disease states that cause that.
Okay, and then in my case, at my first laparoscopy surgery, they cut back the endometriosis a little bit, and I envision it like little skin particles they cut back, but it does grow back or can grow back, right?
Well, if you're very thorough in removing it, I think it depends a lot on sort of certain genetic subtypes of endo. And I wish I could be really specific about what those are, but there are women who have a surgery and they never have recurrence.
Yeah.
And there are other people that have surgery and do have recurrence. And that recurrence can be, in some cases, it can be because the surgery wasn't very good because they just never really removed it. Uh, but even with really expert excision, some people will have recurrence. And
Mhm.
we don't know, like, was it a little bit of disease on the edge of what was cut out and you just couldn't see it? And so this wasn't removed? Or, I think some people also have true recurrence because I've seen people where I've done surgery. I have video documentation of what I did before. As much as anybody can say we completely removed it. And yet 2 or 3 years later, you go back and there's clearly endometriosis again.
Yeah, okay.
It may be that somebody that is developing endo because of retrograde menstruation, like one of the pathways perhaps of endo, that they are, and they continue to menstruate, that maybe they collect some more endo again. Or maybe a person who had endo from a genetic predisposition is sort of like a embryonic rest theory endo, that you remove that widely and it never comes back because the genetic pathway for the endo was something that happened when they were an embryo. Now that's not happening anymore, so the endo is not coming back.
Mhm.
I think that people that have widespread superficial endometriosis are much more likely to have recurrence than people that have like deposits of deep knots of infiltrating endometriosis. That's been my experience, that when people have like big knots of deep infiltrating disease, you widely excise that, do a good job, it doesn't come back.
Mhm.
When people have kind of like little scattered disease everywhere and you remove almost all the peritoneum and the pelvis to remove it all, I think those patients are much more likely to be people that have recurrence in the future. And I think these are genetically different disease states.
Interesting. And from your experience, does it flare throughout the menstruation cycle? And also at the same time, does it stop once you're done with menopause?
So it does tend to flare usually in the week or so leading up to the menstrual cycle. And then during the cycle, it's usually when people have the most symptoms. And that's because the estrogen levels are quite high, and estrogen levels tend to stimulate endometriosis. And then when the progesterone falls off at the end of the luteal phase, you're going to get bleeding and you're going to get kind of a destabilization of the endometriotic lesion. And you're going to get increased inflammation causing pain. This second question was menopause. So endometriosis is stimulated by estrogen. And so after menopause, there's not going to be very much estrogen. And so it's going to tend to be less stimulated. The endometriosis itself will not be gone after menopause. Like if
Mhm.
there is endometriotic implants in the pelvis, they will continue to be there.
Yeah.
Some people will have low enough estrogen levels that they will stop having symptoms. And so there's not really any need to do anything. But some people, are on estrogen replacement for hormone replacement, or maybe they're a little heavier and they make more estrogen just through what's called aromatization, which is a process by which your adrenal hormones get transformed into estrogen. And that happens in fat. So the more fat you have, the more it happens. And some people will make enough estrogen via that process that their endometriosis will continue to be problematic. And I do operate on postmenopausal people, not a lot. It's probably like 5 or 10% of the patients I take care of, but there are reasons to operate on postmenopausal people at times.
And you mentioned estrogen. I think the only real treatment we have currently is hormones, or is there anything else you can, besides pain medication, that really treats the endometriosis?
So, when we talk about treating endometriosis, we got to be careful. Like, are we treating the presence of endometriosis or are we trying to address the inflammation that endometriosis causes? I don't think there's anything that treats endometriosis from the point of view of like making the endometriosis go away. That doesn't
Mhm.
exist. Nothing that does that. There are a variety of things that can decrease the metabolic activity of endometriosis. Progesterone, from many people, can do that. Stopping menstrual cycles seems to help. Just having those big swings in estrogen, if you can kind of get them just to have a low, steady state of estrogen, you're going to tend to get less symptoms. There are also sort of naturopathic / functional medicine approaches to reducing inflammation, such as anti-inflammatory diet. There are a number of supplements that have been shown in studies to reduce endometriosis-related pain, like N-acetylcysteine, curcumin. It's another one. I forget. Those are the two big ones. There's another one too. Vitamin D levels are associated. So people that have low vitamin D have more endometriosis-related pain because vitamin D, the inflammatory pathways upregulated in the setting of vitamin D deficiency. And like in Portland, everyone's vitamin D deficient. There's not enough light and you're not outside enough because
Right.
especially in the winter, people get very vitamin D deficient in the winter. So that's an important thing. So again, those are affecting inflammation from endometriosis. They're not affecting the presence of endometriosis per se.
And I heard the term endobelly. Have you heard that before? Can you explain what that is?
So endobelly refers to some people get a really swollen abdomen particularly when their endometriosis is inflamed, and people refer to that as endobelly, or they say, I feel like I'm pregnant or I look like I'm pregnant.
Mm-hmm.
You have people saying that people come up to them and ask them when their baby's due and they're not pregnant. They're just having swelling. So the belly is a vacuum. There's no air in there. So the only thing that can swell your belly is the bowels. So when the belly is swollen, it's because the bowels are distended.
Mm-hmm.
The reason why the bowels get distended is because inflammation is interfering with the natural peristalsis of the bowel. And the bowel, when the muscular walls of the bowel are contracting appropriately, the bowel is kind of squeezed together and it's pushing the food and stool and so forth through. When the bowel is dysfunctional, it just relaxes and it's getting big. So now the bowel that used to be this big is now this big. I'm not a bowel surgeon. I kind of
It's
am.
okay.
In any event, there's a bunch of bowel in there. And if you make the bowel 3 times as big, your belly is going to be 3 times as big, or it's going to be bigger at least. So that's what endobelly comes from. It may also be related to dysbiosis of sort of gut flora issues. And again, but that's now created gas production in the bowel, is creating bowel distension. There's definitely a correlation between abnormal gut flora and endometriosis and so-called leaky gut. There's been some studies that have shown that people with endo are more likely to have leaky gut type phenomenon. So yeah, it is a correlation. Unfortunately, the endobelly is hard to treat. Like what I have found is that when people have bad endometriosis and they have endobelly, their pain gets a lot better with surgery. I've found that a lot of people continue to have enough inflammation that they get kind of this endobelly issue, and sometimes it doesn't get as much better as they would like. And I don't know what to do about it. It's a difficult problem.
I see. And I know I had doctors that recommended to me to remove my uterus altogether. I'm sure you had many patients where that was the case as well. Can you talk a little bit about that? And what are the late effects of removing the uterus when it then later comes to menopause and all that? Will it have like side effects?
Sure. So people used to believe that if you remove the uterus, you're going to cure endometriosis.
Mm-hmm.
That's wrong. Like removing the uterus does not cure endometriosis. Then people got all hyped up about the fact that removing a uterus doesn't cure endometriosis and therefore no uteruses should be removed. That's wrong too. A lot of people benefit from hysterectomies. The question is that why are you doing a hysterectomy? So when people have severe really bad endometriosis, it's often on the uterus too. It's on everything in the pelvis. And so usually there's endometriosis on the surface of the uterus as well. There can be endometriosis. It's invasive kind of up in the back of the vagina, and you can't remove it all without removing the uterus. There also people have adenomyosis. Like a lot of people with endometriosis also have adenomyosis, which is kind of like endometriosis within the walls of the uterus. We recorded a podcast. If you go back to the endometriosis podcast, we did a whole episode on adenomyosis. So there are plenty of times when removing the uterus is appropriate. I think that what you really want to be removing a uterus is you start out with the patient that doesn't plan on having kids in the future. Like
Right.
if she wants to have children in the future, then, or if they want to have children, then taking the uterus out is not a good option because they will not be able to carry a baby in the future.
Right.
But if they've completed their family or they don't want to have kids, then doing a hysterectomy can often be a helpful thing to do. I just would never do a hysterectomy alone. I would also do a hysterectomy and remove all the endometriosis. Like removing the uterus and not touching the endo is never going to be worked that well. But removing the endo and removing the uterus can often be better than removing the endo alone.
Mhm.
I think you also have to consider that, again, we talked about different mechanisms of endometriosis. We went through this period where retrograde menstruation was like, you couldn't even say it without people just freaking out online that this was like some sort of debunked theory. It's not debunked. Like there's clinical and animal data to show that retrograde menstruation is real in at least some people. And so if that is a reason why a given patient has endometriosis, then stopping menstruation is going to reduce the likelihood it's going to recur. And that has been my clinical experience as well, that people who no longer have a uterus are much less likely to come back later and say, I'm having pain again. And whether that's because of uterine pain that was not addressed or because of actual endometriosis recurrence, I'm not sure, but I'm not willing to throw out the idea that it is coming from the uterus.
Mhm.
That there was a really influential endometriosis surgeon named David Redwine, who was a real pioneer in our field, but also he had a really strong influence online, and he felt very, very sure that retrograde menstruation was wrong. And he told everybody about it very vociferously. And at a certain time, it was almost like the sacred cow to ever say that retrograde menstruation could possibly be true. But I'm not sure why he felt that way. Like there's a reasonable amount of data, particularly in animals, that yes, this may be a part of endometriosis. And so I think it's worth considering hysterectomy for that reason in a person who doesn't plan on using her uterus for childbearing. If a person doesn't plan on using their uterus for the childbearing, it doesn't really do anything. It's a vessel for carrying a baby. Everything else it does is bad. It bleeds, it causes inflammation, it causes pain.
Mhm.
Yeah. The ovaries are intelligent organs. And when I mean intelligent, like if you go to medical school, you learn everything about every organ in the body. And you find out that some organs are really smart and some organs are really dumb. And some organs are in the middle. I would say like the heart, it's kind of in the middle. It listens to signals from the outside and it doesn't really send a lot of signals out, but it listens to a lot of signals coming in about telling it how fast to beat and how hard to beat. The brain's obviously does a lot of stuff. The kidneys, I would say, more intelligent than the brain. The things that the kidneys done are unbelievable amount of signaling in and out of the body, everything about blood pressure and keeping your salt balances right. I mean, kidneys are miracles of complex engineering, bioengineering. The uterus is a dumb bag of muscle. It doesn't do anything. It's there to carry a baby. And so I am happy to put it on the back table in somebody who is having pain from her uterus. Now, the ovaries are intelligent organs. The ovaries have both electrical and endocrine signaling pathways that operate in the body.
Mhm.
Just like, nobody would casually remove a man's testicles, so you probably shouldn't casually remove a woman's ovaries. It's the same organ. It's just a female version of the same organ. And so, person's ovaries make estrogen. Without your ovaries, you'll go into surgical menopause right away. You'll have bone loss, you'll have dry skin, you'll have dry vagina, you'll have over time dementia, increased dementia, brain fog, you name it, all kinds of symptoms from estrogen deficiency. And if you do lose your ovaries surgically at a young age, you probably should replace hormones exogenously to prevent those things. So
Mhm.
I really try to preserve ovaries in everyone I can, but I'm not too concerned about preserving the uterus in somebody who isn't going to use it to have kids.
Mhm.
Now, does losing the uterus, we need to realize that you can take out a uterus without taking the ovaries out. The ovaries are hanging from the side of the pelvis. They're attached to the uterus, but you can separate them from the uterus and preserve them even while taking the uterus out. When you take the uterus out, you will affect the blood supply to the ovaries a little bit. And sometimes people will have a temporary reduction in estrogen production, but it catches up usually within a few months. They will kind of be back to where they were.
Mhm.
There are also some data that show that people that have had their uterus removed will enter menopause, even with the ovaries preserved, will enter menopause a little bit earlier than they would have otherwise. And it's hard to know what any one individual would have done, but when you look at hundreds and hundreds of thousands of women and you look at the age that they get into menopause, a person that's had a hysterectomy enters menopause on the average 2 years earlier than the women that did it.
Interesting.
And maybe it has to do with the reason why they had a hysterectomy. Maybe people that have pelvic pain go into menopause earlier. So there's a lot of selection bias in those kinds of studies sometimes. But nonetheless, objectively, you are losing some blood supply because there's blood that comes up through the uterus, through the uterine arteries that then kind of arcades in with the major blood supply to the ovaries. And so you're going to lose a little bit of blood supply. But the body also has a way of making up for that. Usually if a organ has more than one blood supply and you remove one of those arteries, the other one will kind of swell and make up the difference within months to, half a year. The body kind of rolls itself. So there's not a lot of downside. Some people are concerned about the creation of a prolapse and removing the uterus. That's not a big issue if you do the surgery thoughtfully and make sure that you leave the support structures of the vagina intact, which you should if you do it laparoscopically, which in my opinion is the only way anybody should do a hysterectomy anymore.
Mhm.
There are people that do vaginal hysterectomies. I'm not a fan. If you do the surgery well, you really shouldn't be causing prolapse by doing a hysterectomy. So I don't think that's a real good reason to not do one if there's a good reason to do it.
Gotcha. And another question I have for you, I also have a big fibroid currently in my uterus. It is actually going to be removed tomorrow. Wish me luck.
Oh, well,
Thank you. But does it somehow go hand in hand with endometriosis? Is this like all maybe caused by the same thing or?
fibroids, no. So fibroids are a non-cancerous tumor. Some of the mutations are kind of like cancer mutations where the cells are forgetting to stop growing. Normally when cells run into other cells, that's a signal they should stop growing. Well, with fibroids, you had a monoclonal. One cell has developed a mutation that has caused it to just multiply until you get this big ball of muscle. It's a benign tumor because it's not capable of invading. So it's not a cancer because it doesn't invade tissues, but it can grow and can kind of push on the uterus. It can push on the lining of the uterus, making you bleed more heavily. It may impact infertility, but it's not really related to endometriosis.
Mhm.
Adenomyosis and adenomyomas, which are kind of big balls of adenomyosis, that is related to endometriosis. There's a lot of genetic crosstalk. I mean, there's definitely a overrepresentation of adenomyosis in people that have endometriosis and vice versa.
What is that again? Can you explain that again?
Adenomyosis, that's where the lining of the uterus is growing within the walls of the uterus. And that can cause heavy bleeding, painful bleeding. It's another reason for hysterectomy sometimes. And it's fairly common. It's more common the more children you've had too. When people have had multiple children, they're much more likely to have adenomyosis.
Interesting. And how do you diagnose that?
Well, it's usually heavy, painful menstrual cycles. There are ultrasound findings that can indicate it. You can usually see it on MRI, but also like clinically, if you do a pelvic exam and someone's uterus is kind of big and spongy and
Mhm.
hurts a lot when you push on it, particularly around the time of their cycle, that is a indicator of adenomyosis.
Interesting. And I know you work in an endometriosis center up in Portland, right? And I
Mhm.
saw on your Instagram you have some really new modern machines there. Do you want to talk a little bit about that? What you guys are doing?
Yeah, I mean, we do all of our surgery with robotic surgery. It's not even that new. Like the first robots came out about 15 years ago or so, but we're now through 5 iterations. We actually just got a DV5, which is the 5th generation of the intuitive robot. It's just a way of doing laparoscopic surgery that's very technologically advanced. We have 3D vision, so we can see really beautifully, very high resolution imaging. You have a very stable camera because it's being held by the robot rather than by you. And then you don't actually hold the instruments. The robot holds the instruments and has its own little wristed instruments. And then the surgeon can put their hands in this sort of virtual reality console. And then whatever the surgeon does, the robot does. And it's a real breakthrough, particularly for endometriosis surgery, because it's so technical and very small little structures that our ability to do endometriosis surgery well, in my opinion, is much improved because of the robot. You can do the same stuff without the robot. It just requires more skill and practice. And I think probably you're going to have more blood loss and less precision. Even the people that are really, really good with laparoscopy have the same struggles that I would have doing laparoscopy. It is just, robotics is just a real advance. I don't think there's any downside to it too. So the newest robot has a few nice advances, but really the 4th generation robot is the pinnacle of where we've been at. The 5th generation, I think, was a reason to sell more robots. I'm not sure how much better it is yet. Don't let them hear me say that. I don't think anybody on Intuitive is watching this, but I'm not convinced that the new robot is a revolution yet.
You're on the Judgy Bitch Pod. You can judge as much as you
No,
want.
I think that it's a nice reason to sell another new $2 million robot. But in any event, it's kind of like your iPhone 17 and you have an iPhone 14. It's like, okay, you got a new one. it does
Right.
this makes the same phone calls. It's like, what's new about this?
Yeah.
Um, but if you went back to an iPhone 6, you're like, oh my God, this is a piece of shit. So the really old robots are much worse than the new ones, but I think we're reaching a point of advanced sort of flattening the curve of our innovations. But so we have robots, almost all the hospitals have robots, and that's not unique to me. I mean, robotic surgery has deep penetration in the developed world, particularly in the US, a little less in Europe just because it's so expensive and socialized healthcare systems are better at saving money than we are.
I know. I'm from Germany originally, so I know what you mean.
Well, Germany is a better system because you have a hybrid system where there's a private and a public system.
Yes.
So it allows you to have a good healthcare system that the government can afford with the ability to access some additional things for people that can pay for it. And that's probably the least bad system. People can say that's unfair that the wealthier people can get some stuff, but you're not denying people good, high quality healthcare while
Right.
also allowing for some advances that would not be financially feasible within the public system. And I think that's the best model. And I mean, maybe the U.S. will get there one day, but certainly not under the current administration.
Certainly not. Yeah. Dr. Fogelson, I want to be mindful of your time. I promised you we stay around
Oh,
40
you have
minutes. We're right at 40 minutes. Yeah, look
oh,
at
we
us.
we can keep going a bit more if you have a few questions. That's fine.
That's okay. Do you want to shout out your podcast again? Where can people listen to the podcast? And I'm sure you dive much deeper in the episodes. I listened to a couple of them. I loved it. Shout it out. Where can they find it?
Well, the podcast is secondary. What's most important is the practice.
Okay.
So, I mean, we're at Northwest Endometriosis, nwendometriosis.com. Our office is in Portland, Oregon. If you look up my name, you'll find it. It's Nicholas Fogelson, but also just nwendometriosis.com. If anybody has, endometriosis concerns and they don't have a doctor that they already trust and want to work with, we see people from all over the country and in fact from all over the world as well. We see people travel from everywhere. And the podcast is really a vehicle to talk about what we're passionate about and what we do, but I don't ever anticipate, selling ads or anything. It's not about
No.
that. But anyway, we have a podcast called the Endometriosis Podcast. Shockingly, no one had used that name yet. And my
Is it not
partner,
talked about enough? That's why I'm saying it seems like a new disease that was invented last year.
yeah, I mean, it's definitely that there's a certainly an advocacy community, but I agree it is understood. And I think it's important for men to understand too why, you know, I have a lot of times when men see the videos of the stuff that was inside their partner's pelvis and go, "Oh my God, that's what was going on when you were so miserable." I didn't even, they had a hard time conceiving of how their partner could have been in so much pain or so difficult,
Yeah.
that difficult. And then they look and they're like, "Oh my God." So it's a real thing. And so the podcast we do is fun. We talk about some recent articles and usually pick a topic. And Dr. Moling, my partner, is really brilliant surgeon as well. And so we enjoy having a conversation, and we're going to start bringing on some patients too, or other guests to maybe talk about some specific stories. And I have an Instagram too. It's just my name, Nicholas Fogelson, and people
Yeah.
can follow
I
that if they
saw
want.
on your Instagram you had a patient video recorded who had lung issues, I believe. And you
Yes.
know what? It's funny because I have that too. And mine, I noticed it during COVID. So my thought was, it might be long COVID. So I was with the doctor pulmonarily, whatever. He did testing for almost 2 years and he couldn't figure out why I get winded so quickly. And I still have it. And after seeing your video on Instagram the other day, I was like, maybe there's a correlation to my endometriosis.
Well, endometriosis of the diaphragm, it's very rarely invading the lung. That's pretty rare, but there can be endometriosis of the diaphragm that can inflame the lung. And the common symptom of that is pain in the shoulder because the diaphragm, innervation of the diaphragm is the same as the third, fourth, and fifth cervical nerve root. And your brain doesn't have any space made out for the diaphragm. It's all for your shoulders and your arms that are innervated by the same nerves. And so when your diaphragm hurts, you perceive it as being in your shoulder. And so people
Interesting.
will have pain in their usually my picture's mirrored. I'm touching my right ear, but the right ear, the right neck, and then the upper shoulder is where people perceive their diaphragm. And
Huh.
it's usually a shoulder ache that you just can't reach. People will try to massage it out, and they're just like, no matter what I do, I feel like I'm not even touching the pain. And
Right.
that is because it's not actually in their shoulder. It's a neurologically referred pain that's coming from their diaphragm.
Body's tricking us.
Yes. Well, we have if you go into an old textbook, you have like a homunculus of your brain where it shows, all the gyri and the cortex of your brain, how much of it is, when you look at the sensory cortex, which parts of the brain are devoted to which parts of your body. And amazingly, like a half of the entire sensory ability of the brain is devoted to your hands. And then you look at your feet get a lot too, and other parts of your body get almost none. Well, the diaphragm gets zero. There is no connection between the diaphragm and the sensory cortex in your body.
Hmm.
Is Those nerves are the same. Even though there are some nerves, they end up meeting up with the nerves that come from your arm and your shoulder, and that pathway goes up and it goes to a part of your brain that is for your arm and your shoulder, and it does not perceive as diaphragm.
Interesting.
And that's how a referred pain works, is when you have a pain in one location, but your brain is perceiving it as being somewhere else because of just the way our nervous system is wired.
Very interesting. Do you have an advice for people listening to the podcast and now realizing, oh, I might have endometriosis? All of the or most of the symptoms you mentioned earlier, I have those too. I've been to my doctor. They never mentioned anything. What can I do? Or what if my doctor doesn't believe in it or whatever? Do you have a tip?
Well, I would start out by, you know, you got to work with somebody who has a lot of experience with endometriosis. You can start out by trying to take some birth control pills or progesterone and see if that reduces the symptoms. And if it does, that may be enough. But if you're taking kind of the ordinary medical therapies for painful menstrual cycles and you're continuing to have problems, then you probably should talk to someone like me, because you can go your whole life without an answer, or you can go and look. And
Yeah.
when you go and look and make the diagnosis, we can make things much better. Like, we don't just look and say you have endometriosis. We look and we remove it. And
Yeah.
so people come out of the operating room much better than they went in.
Hmm.
It's not, a lot of times surgeons will look and say, oh, wow, you got really bad endometriosis. And then they leave. And it's like, okay, well, what did you do? All you did is tell a patient that what's wrong. You didn't actually fix it.
Yeah.
But fixing it is technically challenging. So you need to work with someone that does a lot of endometriosis surgery. It doesn't have to be me. I'm not the only good surgeon in the universe, or I'm not only, there are many, many competent and experienced endometriosis surgeons, but your general OBGYN that delivered your baby is probably not. It's
Yeah.
usually one who's done a fellowship at least and has a lot of experience.
More specialized. And if you have another minute, can we talk about birth control for a second? Because that seems to be the treatment that helps the most with the symptoms. But birth control, and correct me if it's wrong, but here in America, it seems to come with a lot of side effects, especially mental health side effects, which I never heard from my German friends.
Maybe they're just stoic Germans.
Oh, maybe that's what it is.
I mean, I believe that birth control in Germany has estrogen and it's the same stuff. In
Yeah,
fact, a bunch of the companies, pharmaceutical companies that make birth control are German companies. So
it's the same stuff.
I like Bayer. I mean, Bayer is German. Anyway, yeah, I'm not familiar with there being a difference. Now, there are some different progesterones that may be in birth control that are in Europe that are not in the US, but I'm not familiar with the side
Hmm.
effect profile being much different. But the progesterone that's in birth control will suppress endometriosis related pain in at least some people with endometriosis, and or just making them not menstruate. Like, if you suppress menstruation, so you only menstruate maybe once every 3 months, that's reducing the number of days that are painful.
Hmm.
So it can be useful, but it doesn't prevent progression. Like, there are people that have severe endometriosis who've been on birth control their whole life, and you look at it and you're like, well, obviously it didn't prevent this, and they may have had less symptoms, but it doesn't seem to stop the disease from progressing.
Yeah. Yeah. And do you have patients that complain about, the hormones making them depressed or,
Yeah.
any of those symptoms?
Some people. So it's not the estrogen. I think it's the progesterone. And there's a bunch of different progesterones in birth control, and some of them have psychological side effects. And it's not the same for everyone. Like, a given one person will be on, say, norgestimate, which is one progesterone, and they'll say, it's great, I'm totally fine. And then another people will feel depressed and anxious on it. And so if somebody's having psychological side effects, they don't necessarily have to stop taking birth control, but they should change to a different progesterone, because have they may not have those side effects on a different progesterone. So if they want to be on it, it's worth a try to try a different one. It's just not worth a try to try this. Like, the same birth control has 20 names. because there are all these different sort of branded generics. And so when you look at the generic name, it'll say ethinylestradiol, which is the same estrogen that's in all of the birth control. And then it'll say a name like norethindrone acetate or norgestimate or drospirenone or levonorgestrel. There's like 6 or 7 different progesterones. And if you take 2 birth controls that read exactly the same, ethinylestradiol and then norgestimate, and you get another one with a different name that says ethinylestradiol and norgestimate, it's the same drug. It just got rebranded by some other manufacturer. So you need to take a birth control that literally has a different progesterone in it, and then you're kind of some chance that it will not have the side effects that the other one did.
And weight gain, I think, is another big topic when it comes to birth control.
And that's mostly going to be older progesterone. So the older progesterones are more what we call mineralocorticoid active. They're causing fluid retention, and they also stimulate appetite. And so we use really strong progesterones in cancer patients to get them to eat. And so it's like the opposite of the fluid retention is more common with the older birth controls. So norethindrone acetate and norgestimate are going to cause a lot of fluid retention. Levonorgestrel less so. And then you get into like spironolactone related ones like drospirenone is significantly less fluid retaining. In fact, it even is fluid losing. So birth controls are not all the same in that way.
Yeah. Okay. And since this is a Judgy Bitch Pod, and I promise I'll let you go after this, is there anything within this topic that gets you really bitchy?
Well, I mean, it drives me nuts when I have patients that sometimes have severe disease, and I do an exam and I find some endometriosis like eating through the wall of the vagina, and you can see it there. And they said, "Oh, I've had pelvic exams for the last 10 years and nobody said there was anything wrong." And I'm like, how can you say there's nothing wrong? I mean, what that says is that their doctor or doctors or nurse or PAs or whoever was in their pelvic exam was just kind of going through the motions. Like they weren't actually engaging their brain and assessing anything. They were just like, "Hey, I'm just going to feel your uterus, whatever." And I'm like, well, they may as well not do a pelvic exam, and there was, the American Academy of Family Medicine has a statement that pelvic exams are pointless. They just think that you should do a pap smear and there's no point doing a pelvic exam with the fingers in the vagina and you feel the uterus and ovaries. It's like, well, it is pointless because they don't get trained and do it well. And if you're not actually experienced at it and paying attention to what you're doing, then it's pointless. You're just doing something uncomfortable for the patient. You may as well not do it. But if people do it thoughtfully, they find stuff. And it drives me nuts when I have a patient who obviously has severe endometriosis who have been ignored by even board certified OBGYNs who just, I don't know, I guess they're just working too fast and not noticing it.
Yeah.
In that person's defense, they're forced to see 25, 30 patients in a day and they got 15 minutes to do what they're doing. And they're just
But it doesn't matter. If you don't do your job correct, you don't have to do it at all,
It's not, well, yeah. So that pisses me off. I mean, I don't know, it pisses me off is I'm just like, geez, this is sucks. But fortunately, we're able to address it.
Yeah. And that's why I'm so glad I found you and you came on and you shared your knowledge with us. Tell us one more time, where can we find the center?
Northwest Endometriosis and Pelvic Surgery. We're in Portland, Oregon. It's endometriosis.com. And happy to chat. And we do free consults too. If people are interested in coming potentially being our patient, we're happy to do a Zoom call and review your records and have a 30-minute free assessment. And then if it's appropriate to come, sometimes people just come and have surgery. Other times they come and we do a consultation in the office and then decide if we're going to have surgery at some later date.
Oh, that's good to know. Thanks for sharing that. And thank you so much, Dr. Fogelson, for coming on. Thank you. It was great having you. You shared great information with us. Bitch Besties, if you have any questions, reach out to us, reach out to Dr. Fogelson, and please stay on for one more second. Thank you so much.
Okay.
Bye. That was it for today. Thank you so much for listening. And if you are as excited and opinionated as Peanut and me, please give us a follow on Instagram at the Judgy Bitch Pod. And don't forget, please also tell everybody you know about this new podcast so they come and follow us as well. We would much appreciate it. Would you like to be part of it? Sure, go ahead. Send us a DM with your feedback, your hot takes, and your unapologetic opinions. We might read them next time. And last but not least, don't forget, please follow, review, and rate wherever you listen to this podcast. See you next week. Cheers, bitches.